going to discuss today the impact of antenatal multiple micronutrient supplements, which I will refer to as MMS, on women's health and pregnancy outcomes. It's important to recognize the high prevalence of micronutrient deficiency in women of reproductive age around the world. These data come from national nutrition surveys that have assessed various vitamins and minerals in women of reproductive age. As you can see in the different regions, there are a number of micronutrients that have high prevalence of deficiency. This is not only iron as represented here by IDA or iron deficient anemia, and folic acid represented here by folate, where iron and folic acid are given during pregnancy, but also other vitamins and minerals such as zinc, iodine, vitamins D, B12, and vitamin A. So these deficiencies are important in the regions, especially in the low and middle income countries. And the deficiencies are largely, but not entirely, corrected by multiple micronutrient supplements during pregnancy. The information I'm going to show you on the effect of MMS versus iron and folic acid, or IFA, on the birth outcomes comes from a large number of randomized controlled trials. The first set is the Cochrane review updated in 2019 that evaluated these trials and selected birth outcomes. And the second set of information comes from an analysis of individual patient data. That is, the individual trial information for many women was collected, and this allowed more analysis, more outcomes, and more analysis of modification of those outcomes by various characteristics of the woman or the supplementation. The information from the Cochrane review is in the middle column, and it has only a few outcomes, and the information from the IPD meta-analysis is in the far right column, and I'll spend more time on that because it has more information, and also the Cochrane review and the IPD meta-analysis show quite similar results. For the IPD meta-analysis, the effect on small for gestational age, low birth weight, very low birth weight, preterm birth, and very preterm birth are all statistically significant. These are all meaningful outcomes. Preterm birth is the leading cause of death in children, neonates in the developing world, and especially important is the large effect on very preterm birth. The effect on small for gestational age or low birth weight these are also very important because this represents fetal malnutrition, and this relates to further risk of mortality after birth and poorer linear growth after birth as well. There's also an effect of MMS on stillbirths, which was statistically significant in the IPD meta-analysis. As I said, the IPD analysis could examine various modifications of the effect of MMS in comparison to IFA. So these represent in the column on all pregnant women the effects that I just showed in the previous slide, just expressed in a different way. So an 8% reduction due to MMS compared to IFA for stillbirths, for example. But what is notable here is that in the IPD analysis, women who were anemic at the time of supplementation had a larger effect on stillbirths and also a larger effect on low birth weight and on small for gestational age. Interestingly, they had a large effect on mortality in infants in the first 6 months of life as well, which was not found with all pregnant women. Underweight pregnant women who have a BMI of less than 18.5 kilograms per meter squared have similar effects, but except for preterm births, where they have a larger effect than seen for all women. So in conclusion, there is a clear superiority of antenatal MMS versus IFA. There's strong evidence, as I've said, for the reduction in stillbirths, low birth weight, small for gestational age, and preterm births. The interpretation of the effect modification is be best looked at in regard to populations, because it may be difficult to screen women who are anemic or who have underweight and only provide supplements to them. So the interpretation I would offer is that populations that have a high prevalence of anemia or of underweight in women will have a special benefit in regard to some of these outcomes. And that is, particularly anemic women would have a greater effect on stillbirths, low birth weight, small for gestational age than non-anemic women, and the reduction of deaths as well after the first 6 months after birth. So this is an important guide to where we might want to implement MMS in the areas in the countries where there's a very high prevalence of anemia. I didn't show the results for sake of time, but in these trials, they did not demonstrate any evidence of serious adverse effects with MMS versus IFA. Thank you.